Good morning, everyone. So, last 2 days are looking very fruitful, and we have come to the last session of the lectures. So, as we are enforcing since yesterday that ILD requires a comprehensive kind of care. Beyond ILD, we need to focus on the overall well-being of the patient. So, there are few components which are the part of comprehensive treatment. One of those is pulmonary rehabilitation, and sometimes patient can have very difficult to treat symptoms, for example refractory cough, and sometimes patient will require lung transplant, especially patient is IPF, so most of these patients are candidate for lung transplant. So divulging all these aspects, this session is dedicated to that. So first I will invite Dr. Irfan Ismail Ayub. I am happy to say that he is AIMS alumni and he was the first DM candidate of our institute. Currently he is working as assistant professor at the Department of Pulmonary Medicine at Ramachandra Medical College, Chennai. And he is a very good speaker. We are hoping to hear from him. Over to you.
Thank you, sir. A very good morning. At the outset, I'd like to thank my teachers, my students, of course, our patients, and the organizing committee for inviting me to be part of this academic event. I'll be talking on two aspects. One is pulmonary rehabilitation and the other one is on oxygen therapy. I've split my talk into two parts. First of all, I'll be talking on pulmonary rehab. In terms of pulmonary rehabilitation, I will start off with this Cochrane review published in 2021. Here they have looked at 21 studies compared to the previous review that came out in 2012. They had added 7 more studies, and this looked at pulmonary rehabilitation in patients with specific to ILD for a duration which was given up to around 48 weeks. And there were benefits in all domains in terms of exercise capacity, health quality, in terms of dyspnea, in terms of peak work capacity and so on. So if you look at the plots, you can see that most of them were actually favoring pulmonary rehabilitation. The 6-minute walk test distance on a mean average moved up at least around 40.7 meters. You can see everything is moving towards the right of zero. And in terms of the peak work capacity, again, there was an improvement in terms of 9.04 watts of work. Dyspnea scores improved, and also the St. George Respiratory Questionnaire as well as the Chronic Respiratory Disease Questionnaire scores also improved. Overall, the Cochrane review summarized saying that it improves functional capacity, exercise capacity, dyspnea, and the quality of life. So I think there's nothing much to say here, but pulmonary rehab works across the board in terms of all chronic respiratory diseases, including COPD and ILD, and the same applies also for ILD as whole. The question here is, I decided to look at a few publications to bring forward certain points with respect to pulmonary rehabilitation that we can take home. This is a paper that was published in 2017 in Thorax, which tried to look at the predictors of what or when pulmonary rehab will be successful in patients with ILD. So this looked at around 142 patients with ILD, of which 61 had IPF, and they were randomized to 8 weeks of supervised exercise training, or they were usual care. And they found that, again, as known, pulmonary rehab increases the 6-minute walk distance, the quality of life indicators as well. The larger improvements were seen in patients with IPF compared to CTD-ILDs, but consistency was more in CTD-ILD at 6 months. Now, two things here: lower baseline 6-minute walk distance and worse baseline symptoms were associated with greater benefit if they were offered rehab. And at 6 months, sustained improvements in the 6-minute walk distance and the symptoms were associated with better baseline lung function and less pulmonary hypertension. So the take-home point here in this paper, which was published in 2017, is that if patients had better lung function at the start and they had lesser pulmonary hypertension, they were more likely to be successful in pulmonary rehab. That means we need to start early with respect to pulmonary rehab in patients with ILD rather than to wait till they develop major symptoms. It's not just exercise, it involves other components. The Cochrane review has clearly mentioned that it includes nutritional advice, stress management, occupational therapy, physiotherapy, and education. And it has looked at core areas which looks at staying well with ILD, which includes vaccination, regular exercise, and good nutrition, keeping fit and strong even after pulmonary rehabilitation, oxygen therapy, managing symptoms like breathlessness and cough, overcoming fatigue, and also managing psychological issues like anxiety, depression, and panic. There are a lot of barriers to rehabilitation. This is actually a collection of points taken from 2 papers which have looked at what prevents pulmonary rehab being taken off. And there are patient-related factors like lack of perceived benefit or a fear of breathlessness doing exercise, or travel issues, or even cost issues, waiting time, and burden of illness. There are also issues with respect to the doctor itself. There were knowledge domains where the clinician itself felt pulmonary rehab may not help this patient, or sometimes the patient understanding of rehabilitation with respect to how much the physician had explained to the patient also was an issue. Belief issues with respect to also both the physician and the patient were recognized, and there were barriers at all levels with respect to referral, uptake, attendance, and completion. See, if you look at it, this is an example of a patient who had extensive ILD. You can see that this is IPF. This patient actually was a chronic smoker. He also had upper lobe emphysema, so technically CPFE. He has moderate pH. He's got bilateral osteoarthritis knee. He's got an albumin of 2.0, bilateral leg edema. He's on stockings. And in addition to that, he's got tuberculosis. You can see that the catheter is showing orange color urine. He's on ATT. This is everything that can go wrong with respect to getting out of bed. This patient has been limited to bed for the last 6 months. Ever since his wife died, he's got depression. And even then, you can get these patients to walk. You can get these patients to push, first with basic warm-up exercises, then moving on to strengthening exercises, and then start moving endurance. You can see that this patient, you can see that he's not even initiating the first step. But you have saturation monitoring, and you need to initiate these patients to cross the barriers with respect to pulmonary rehabilitation. Subsequently, this patient coming up on follow-up in 6 weeks is actually walking into the clinic. One aspect that you can do to improve rehabilitation that I would like to share in this presentation is tele-rehab. Now, there's a lot of takeoff in tele-rehab. There have been a lot of reviews, a lot of publications from Southeast Asia, from Japan. And this was a Cochrane review published in 2021 that looked at 15 studies, but majority of these patients had COPD. We are not going to say that it is applicable to ILD, but in terms of primary pulmonary rehab, there was little or no difference with respect to quality indicators like 6-minute walk test and quality of life indicators. And there was a higher completion rate with respect to tele-rehab, 93% compared to 70%. They looked at diary entries to see whether these patients had been consistent with their exercise protocol. But when compared to no rehab, trials of primary rehab are actually much better in terms of clinical outcomes when delivered also as a maintenance rehab also. And there are no additional adverse effects if you compare to in-hospital or in-hospital rehabilitation. But when you look at patients with ILD in tele-rehabilitation, the problem here is we need to monitor oxygen saturation, and we need to look at oxygen delivery during exercise, which will be a technical challenge, unlike maybe patients who have stable COPD who do not require oxygenation. This is the ATS guidelines on pulmonary rehab. This was for chronic respiratory diseases, but points 3, 4, and 5 dealt with ILDs. The take-home message was it was a strong recommendation to go for pulmonary rehabilitation with ILD with moderate evidence. And should adults with pulmonary hypertension also undergo rehabilitation? The question was, the evidence was low, but it was a conditional recommendation. And regarding tele-rehabilitation for chronic respiratory diseases, a strong recommendation, but with moderate evidence. There's no talk on pulmonary rehab without talking about the components of the pulmonary rehab program. Of course, pulmonary rehabilitation document itself, the ATS document itself will be running to around 30 pages and probably will require a one-day course. But to make it very simple, it has 4 components. You have warm-up exercises, you have strength exercises, endurance exercises, and then you have the cool-down exercises. The take-home message is make sure that these patients do it at least for 30 minutes, 4 days a week. And when it comes to breathing, ask them to exhale during the most difficult part of the exercise. For example, if they're doing the strengthening exercise, they're carrying a water bottle in their hand, make sure that they exhale when they're lifting the water bottle and they inhale when they're bringing the hand down. The strengthening program, try to ask them to carry weights that are likely to make someone feel just about tired, but not too heavy weights. So the quality of the weights also matters. Say, for example, if you're lifting the leg, you can maybe say, ask him to start with a boot rather than put a weight on the foot and so on. And the endurance program, of course, an acceptable level of breathlessness. And when he starts facing that breathlessness, then he should take a short break. These are most of the pictorial diagrams that I've looked at, which are available in multiple pulmonary rehab charts. You can see that the warm-up exercises are very straightforward. You just ask the patient to move their head left or right or down and up, and sitting on a chair, extending the foot and leg and so on. And then you have the strengthening program where you make the patient stand and start lifting the leg and also try to push against the wall and try to carry weights, say a ball or even a boot in the leg or some weight which has been attached to the foot. And then you have the endurance program, which is walking, which I showed you in a video just now. And then you have climbing up steps and climbing down steps. And finally, you have the cool down exercises, which again are similar to warm-up exercises, but in a reverse direction. So pulmonary rehab technically is a very long thing to master, but it's something that should not inhibit us from getting into the program. I think yesterday we had our transplant physician who was telling us that pulmonary rehab actually does wonders for patients with ILD who are walking in with potential, say, lung transplant registry entries. Moving to the second part of my talk, which is on oxygen therapy in ILD. Oxygen therapy in ILD, we need to categorize our patients with ILD who may require oxygen at 3 different levels. Those who may require oxygen at rest, those who might require oxygen on exertion, and those who might require on nocturnal hypoxemia. So I'll be splitting this oxygen therapy into these 3 groups. I'll start off with hypoxemia at rest. This is a Cochrane review in 2001, which is very interesting because it has only looked at only one publication, and that was an unpublished paper. They looked at patients who had severe hypoxemia, defined as PO2 of around 45 to 60, and they had 62 patients. 49 of them had idiopathic pulmonary fibrosis, and there was no significant difference in terms of mortality between the LTOT arm and the room air arm, either at 1 year or 2 years or even 3 years. This is basically a very low quality evidence, and the final take-home message from this Cochrane review was give oxygen. The reason is because you are seeing patients with low saturation, and you may not be able to prove the benefit of this oxygen therapy, but you have to proceed with oxygen therapy because most of the evidence is extrapolated from COPD trials. So this latest review that looked at why are we still giving oxygen when we don't have evidence, even after that Cochrane review, there is no strong evidence to suggest that oxygen works. But you know that ILD patients have chronic resting hypoxemia, and the use of LTOT is largely based on the 2 large RCTs from COPD, which have looked at giving oxygen to improve survival in patients who have severe hypoxemia for at least 15 hours a day. And most of these ILD studies, most of these ILD guidelines, which includes the ATS or which includes even the Australian New Zealand guidelines of last year, or I mean this year, or even the BTS guidelines or NICE guidelines, all of them have extrapolated only the COPD guidelines and have suggested the same cutoff, namely give O2 for at least 15 hours a day. If you have severe hypoxemia, PO2 less than 56, or anywhere between 56 and 59, and if there is end organ damage in terms of pulmonary hypertension or right heart failure. And whether this really works for patients is unclear. Are ILD patients different from COPD patients with respect to LTOT? This is actually a letter to the editor, which was published in ERJ in 2021. Where the group looked at their data, 205 patients with fibrotic ILDs, of which IPF was around 94, average 67% of them were males, and the average age was around 70. They all had moderate to severe disease, FVC around 66 and TLC of around 39, and they were followed up for 18 months. And moderate and severe hypoxemia was seen in 28 and 25%. Now, when I followed up these patients, if you look at the left picture, you can see that they have looked at patients who were having severe resting hypoxemia, moderate resting hypoxemia, and isolated exertional hypoxemia. The isolated exertional hypoxemia is the one which had the better survival. But if you look at the severe resting hypoxemia and the moderate resting hypoxemia, they were almost more or less similar. We are trying to say that in COPD patients, if the PO2 is less than 56, that means the severe resting hypoxemia, we give O2. And in COPD, when there's moderate resting hypoxemia, anything above 56, but there's no end organ damage, we don't give O2. But here you can see that the moderate hypoxemia behaves like the severe hypoxemia in ILD, which means that we cannot just simply extrapolate the COPD guidelines to ILD and probably have to lower the threshold for starting O2 in patients in ILD. And if you look at the second picture on the right, when you look at an overall ILD versus COPD, you can see that the COPD has a better survival, the ILD has a very lesser survival, and you can see that the survival drops around 2 years or 3 years. You don't have a timeline where you can actually give O2 for these patients to see whether they actually benefit or not. Following this was a study which was done by a Sweden group. This was known as a discovery trial. So they said that if you are thinking that moderate hypoxemia patients are also behaving just like severe hypoxemia patients, why not give them also O2 and see whether that improves? And they found out that it did not. So out of 17,000 patients, they had moderate hypoxemia in 470 and 2,408 patients had severe hypoxemia. And they found that ILD patients on LTOT had lower transplant-free survival after 1 year and 2 years, and it did not differ in patients where they had moderate hypoxemia on O2 or severe hypoxemia on O2. And they were still holding on the same line, showing that O2 may not have made much of a difference in terms of survival. Coming to the second part of oxygen therapy is an exertional hypoxemia. Why would oxygen benefit patients on exertion? They already have restrictive physiology, they have reduced volumes, and they have early exercise intolerance. So there will be an exercise limitation in these patients because of ventilatory mechanics, impaired gas exchange, and circulatory limitation. So all of this gives you a milieu where you know that oxygen is likely to benefit. So the basis of giving oxygen therapy in patients who are exerting and having hypoxemia on exertion comes from this initial paper which was published in 2006. In 197 patients with IPF, they noticed that patients who had desaturation during the 6-minute walk test to saturation levels below 88 had an increased mortality. And they found that the walk distance did not have any effect on mortality, was not a predictor of mortality, but the saturation less than 88 on a 6-minute walk test means that they were more likely to die. So this gave the impetus to possibly give O2 for these patients. Similar results have been produced similarly multiple times. Even the latest one, which was published this year, also showed that in addition to the original study which was published initially, showed that the 6-minute walk distance also could predict higher mortality. That means lower 6-minute walk distance could also mean that they had a greater chance of mortality, which means that if you were to give O2 to these patients and try to keep the saturation above 88, and if you are able to increase the 6-minute walk distance also, would that mean that survival improves? Is something that is not very clear, but this was actually a paper that looked at predictors of mortality with respect to the 6-minute walk test. So the problem why we are not able to produce results saying that when you give O2 for patients on hypoxemia when they are walking, why is it that they are not improving, is because the study protocols differ from different studies. And also patients may not actually achieve maximum effort when they are doing their physical activity, say at home, unlike when we are doing a 6-minute walk test. So these are two protocols which are published in 2012 and 2011. You can see that different authors have different ways of looking at their protocols. Here in one protocol, you can see that when the oxygen saturation dropped below 90, they said that they terminated the test, and then they added O2 2 liters, and then they again restarted the test and tried to see whether the saturation dropped or not until they went up to as high as 6 liters, trying to keep a SpO2 above 88. And then you have another study where they have tried to break it up, trying to see whether you could increase the oxygen saturation with respect to the flow and try to keep the saturation and so on. So you have different protocols trying to see how much of O2 do you need to give, at what level do you need to maintain the SpO2 during exertion to ensure that you can get an effect on mortality. The Cochrane review, which looked at a lot of these publications, was published in 2016, a large number of records, but finally they turned out to only have 3 studies which had qualitative analysis. All of them had IPF, and all of the studies were done in hospital, and the results actually showed that in 2 studies there was no beneficial effect on exercise capacity. That means we are talking about the distance that you can walk on a 6-minute walk and any effect on the exertional dyspnea. Neither of these studies actually looked at titrating the oxygen to keep the SpO2 above 88 during the exertion. One study documented that there was an increase in exercise capacity as assessed by endurance time with the supplemental oxygen, but they did not look at other quality indicators like health-related quality of life, survival or cost, and other, say, adverse effects were not observed. So maybe we are looking at the wrong objective here. We remember the ATS document that said that rather than looking at survival, rather than looking at, say, for example, exercise capacity, we should look at multiple other domains with respect to ILDs. So you can look at health-related quality of life, functional status, psychological and emotional well-being. So subsequently, we have the AMBOX study, which was published in Lancet Respiratory Medicine 2018, which instead of looking at how much a person can walk when you give O2 or how much is the saturation dropping, let's look at what happens to their dyspnea, what happens to their quality of life. So this was a prospective open label mixed method crossover RCT with 84 patients. All of them had fibrotic ILD, and these are patients who were not hypoxemic at rest. They only developed hypoxemia only on exertion, and they had a saturation drop to less than 88%, and they had stable ILDs. They did not have a recent exacerbation, and they found that if you give them oxygen, there was a significant improvement in the King's questionnaire, and also in terms of breathlessness and activity and chest symptoms. They did not look at a psychological domain. The most common adverse effects were, of course, upper respiratory tract infections. There were some deaths, but they were common in both the groups. And ambulatory oxygen, their take-home message was, is associated with improved health-related quality of life in patients who have ILD, who have exertional hypoxemia. So probably rather than looking at how much they can walk, we should look at probably how much better they feel when they are on O2 and they walk. Subsequently, we have other papers that have also looked at other parameters like, say, for example, dyspnea perception and exercise tolerance, and they also showed that these parameters improve when you give oxygen to these patients who had hypoxemia only on exertion, but who had room air normal saturation. But we were not able to extrapolate, we're not able to replicate the same results in all studies. This is an older study which again failed to show the same results as the earlier studies. Here you can see that ambulatory oxygen on exertional dyspnea in IPF patients who had no resting hypoxemia failed to actually show any difference in terms of dyspnea. But when they looked at a selective subgroup of these patients, they found that some patients may have had an improvement in dyspnea. Maybe what we're looking at is how much of O2 do you need to deliver during that exertion, and that is something that probably there's no clarity on. What is the target saturation you need to reach when you're giving these patients? While we're talking about 6-minute walk test, there is a paper that looked at how much time do they take to recover from the 6-minute walk test when they had a desaturation, and this looked at the time duration, and they found out that if someone had to spend at least around 2 minutes, 135 seconds or so with desaturation less than 88 after finishing the 6-minute walk test, there was a higher chance of mortality. So it means that you need to give O2 not only during the exertion, you need to give O2 even following the exertion at least for the next 2 to 5 minutes. The third part of hypoxemia in ILD is nocturnal hypoxemia. It's associated with adverse outcomes in ILD patients. This study looked at ILD patients who included 44 patients with IPF, and this was a sleep study, a level 1 sleep study, and mild OSA was observed in 62%, and there was a lot of REM-related events, and at least 10% of the total sleep time where there was a saturation less than 90, which is designated as nocturnal oxygen desaturation, was present in at least up to 35% of patients. That means in 1/3 of patients you can have a TST time less than 90, 10% of the TST time less than 90. A lot of indices of hypoxemia occur during sleep, which include nocturnal desaturation and also includes other forms of desaturation with respect to mild OSA. And these group of patients had a higher chance of developing pulmonary hypertension. And these patients also had a poorer prognosis. So these are patients that we're looking at who are not hypoxemic when they come to the clinic, but they're hypoxemic at night. The only way you could recognize this is by doing a nocturnal saturation recording or a sleep study. A systematic review published in 2021 showed that it's quite common, and it's almost having a pooled prevalence of around 37%. That means 1/3 of our patients who are not hypoxemic during daytime are likely to be hypoxemic during sleep. And DLCO and pH, pulmonary hypertension on echo, was consistently high associated with this nocturnal hypoxemia. There is no consistent association between the nocturnal hypoxemia and the type of ILD or the severity of ILD. So irrespective whether the ILD patients are quite severe or not, they are likely to have, at least in 1/3 of our patients, nocturnal desaturation. Some supplemental oxygen may help to relieve this nocturnal hypoxemia, but the results are not very strong. One thing I want to mention about in nocturnal hypoxemia is that there is a hypopnea variant form of obstructive sleep apnea, which is quite commonly reported in OSA. There are only 2 papers actually which have actually published it, but they have reviewed saying that when patients have OSA in ILD, there's a more predominant hypopnea type of pattern, and they have this hyperapnea followed by hypopneas. And very, very interestingly, these patients, you can see that in the first sleep epoch compared to the one below, you can see that there's no difficulty in terms of the thoracic belt and the abdominal belt, so that you can see that those hypopneas are not obstructive, they are actually central events, unlike the one which is below. And when they gave CPAP therapy to these patients, it did not get obliterated, but when they gave O2, just around 3 to 4 liters, these events actually disappear. So we have a pattern of hypoxemia, which is nocturnal. You also have a pattern of hypopnea predominant OSA in these patients who actually are responding to just plain simple O2 rather than CPAP therapy. So nocturnal desaturation, quite common in up to 1/3 of our patients, and probably needs a complete evaluation with respect to a sleep study, probably a level 1 study where you can actually identify these subgroup of patients. But the question is, when you give O2 to these patients, does it improve outcomes? Is something that probably studies are still further required. I'll finish off with oxygen therapy guidelines from the ATS 2020, which is absolutely similar to all the guidelines which have come out from all other societies. And the recommendation is that should long-term oxygen be prescribed for adults with ILD who have severe chronic resting hypoxemia, which means PO2 less than 56, or anything between 56 to 59, but with organ damage. The recommendation is strong, but you can see that there's only one unpublished data. No other studies that have actually looked at it, because this subgroup of patients usually die within 2 to 3 years, and you don't have time to actually see whether they have good quality results. And should ambulatory oxygen be provided? Again, this is a conditional recommendation, even though you have that AMBOX trial and so on, but it's a low quality evidence, and it looks at only the quality of life indicators, which shows improvement, and also in the dyspnea. The exercise capacity distance may improve as per 1 or 2 studies, but it's not strongly supported. And this 8 days guidelines has also shown what are the different types of oxygen delivery devices that are available in the market and what we can prefer to the other with respect to our patient selection. I'll finish off with follow-up on oxygen prescription. There are some studies that have looked at patients who have been prescribed O2, and then they went back to these patients either by telephonic interviews or by questionnaires to see whether there is a change in quality of life. When the oxygen was started, what was expected from the patients? Patients thought that their physical function and quality of life would improve. And as expected, they're saying that they did have some improvements, and they also expected some limitations. They felt that after starting oxygen, they might have some limitations, that they will not be able to come out of the house and so on, and those limitations became more pronounced. They felt that they were actually much more pronounced and unpredicted as to what they had anticipated. There are a lot of reports of tripping on the tubings, there are reports of cost issues with respect to O2 therapy, but despite challenges, all patients usually come back saying that they feel better. So in terms of subjective quality of life, they feel better, and their expectations are also improved. Even we have done telephonic interviews for all our patients who we have prescribed O2. The reason is because we have started oxygen services in our institute. So we have initially been discharging patients with on home oxygen, where we actually give these patients to, say, an outside market which is unregulated. People are actually selling or maybe renting out oxygen concentrators for like 4,000 to 5,000 rupees, and we realize that these are patients who are actually potential patients who could come back to us if we were to offer rental services, and we have started offering oxygen services from our own. This is jovially called as SOS, and we have found that these patients actually come back, they get better follow-up, we're able to reassess them, we're actually finding more opportunities for vaccination, we're finding more opportunities for reassessment of their lung disease. Summarizing on pulmonary rehab, the first part of my talk, pulmonary rehab, as I've told you, has beneficial effects on multiple parameters, and we should not just look at, say, the walk distance or the work capacity, but it also looks at improvement in the health quality of life. And apart from simple exercises and endurances, there are other important domains like vaccination, education, oxygen therapy, and even psychosocial issues. The barriers to rehabilitation exist with respect to both the doctors and the patients, and they have to be identified, and they should be probably sorted out. And we have seen earlier that pulmonary rehab should be started as early as possible, because the lesser the pulmonary hypertension and the better is the lung function at baseline, means the better the chances of getting a complete rehab completion rate. And tele-rehabilitation is an option, though it has been studied in COPD. It can be offered for patients who with ILD. And summarizing on oxygen therapy in ILD, long-term oxygen therapy is a recommended guideline by all international guidelines, including all statements. Even though there is no strong evidence, it's all extrapolated from COPD guidelines. And when you're looking for exertional desaturation in patients who are having no resting hypoxemia, do a 6-minute walk test in the OP. And if the saturation drops below 88, again, we don't have strong evidence to say that we need to give O2, but we do start O2, target an O2 saturation above 88 on exertion in the OP setting, and try and get back these patients again, coming back on follow-up to see what is their health-related quality of life and so on. And when it comes to nocturnal oxygen, there is no output that we can measure, but if patients are documented to have nocturnal desaturation to less than 88, we should offer them O2 to target a nocturnal saturation level above 88 during sleep. Thank you.